welcome you to our conference this morning, which is devoted to the merit-based incentive payment system, a word probably very few of you could recite, also known as MIPS. And MIPS was part of the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA. And to both physicians and to many in Congress, the first thoughts about MACRA are that it ended the Sustainable Growth Rate, or SGR, a policy enacted in 1997 that spun out of control a few years later and occupied Congress for over 10 years with short-term fixes to finally get a handle on it. But MACRA not only ended SGR, but it also put in place reforms in physician payment for the Medicare program. Most attention has been to the bonus for physicians participating in advanced alternative payment models. And as I say, most attention, it's not so much the number of physicians getting a 5% bonus, but that here is Congress speaking, pointing the way to how it wanted the Medicare program to evolve. And this was very broad consensus in Congress, and I think very much applauded throughout the healthcare system. But MACRA also included MIPS, which applies to physicians not participating in advanced alternative payment models. It streamlined some existing pay-for-performance programs in Medicare. Now, MIPS has had what you might call a rocky start. CMS delayed parts of it and exempted very large numbers of physicians in smaller practices. Physicians raised concerns about the burden and the cost required to do the reporting required in MIPS, and policy analysts examined the track record of the measures and raised concerns about their relationship to the quality and cost goals and whether they reliably identified good and bad performers. In January, MedPAC voted to recommend to Congress that MIPS be eliminated and that a new voluntary value program be established that would measure the performance of groups that physicians would form on a voluntary basis. This conference is organized to discuss the recent experience with MIPS and ideas to address its shortcomings. Our initial announcement listed Joe Grogan as the opening speaker. He had to drop out because of a scheduling issue, so we decided just to proceed with our two panels. The first panel is going to discuss how MIPS is working. It's going to focus on the experience of different types of physician practices with MIPS. And the second panel will discuss ways to reform MIPS. The first panel will be moderated by Kavita Patel, who practices medicine at Johns Hopkins Medicine and contributes to our work at the USC-Brookings Schaeffer Initiative for Health Policy as a non-resident fellow at Brookings.
All right. Thank you, Paul. And I'm going to go ahead and I'm going to briefly introduce our panel. Each panelist does have slides, and as a result, I couldn't help but I was able to get some slides myself, but as Paul mentioned, and I know there are a lot of you watching on the webcast, we are going to talk about how MIPS is actually working on the ground, but we can't help but offer a potential foray into some solutions, or at least trying to bridge to our second panel, which Paul will be leading. So starting to my right, we have Valinda Rutledge, and they're in the order of appearance as well, the Vice President of Public Payer Health Strategy from the Care Coordination Institute of the Greenville Health System in South Carolina, Sherry Erickson, the Vice President of Governmental Affairs and Medical Practice at the American College of Physicians, Erin Liss, the Director of Strategy and Business Development at Tennessee Oncology, and Tim Groniger, Senior Vice President of Development and Strategy at Caravan Health. All of these people have much longer bios associated, but in the interest of getting us to what we want to do, they can each talk about kind of their respective roles during their presentations. I decided to put in a couple of very pragmatic slides around, here we go. Let's see. I just have to pull up the PowerPoint myself? Okay. That sounds like I'm being a little, all right. So, all right, every single one of you have to pull up the PowerPoint. and then somebody's going to make it sync with the screen. So what I decided to do while we're waiting for it to come up, I mean, it's on full screen. It's on my full screen.
On the presenter.
Ah, okay, everybody has to do this? Okay. All right, I was a chief resident, so I'm ready for all the, okay, so here we go. So I wanted to just do this as a ground refresher because I think that everybody on both of these panels are extreme experts for the MIPS program, but just wanted to kind of offer a little bit of like level setting for the categories. And by the way, last week the administration released the proposed rule around the physician fee schedule and the QPP program and a number of other changes. So there's actually some tweaks and adjustments to even what you see here. But needless to say, as Paul mentioned, this was all an attempt to make something better than what was previously there in various programs, and some of us might talk about this. I wanted to just bring up, I practice the plurality of my time in an employed, community-based, not an academic, community-based primary care setting that is on fee-for-service. 98% of our revenue is fee-for-service, 40% of my practice across 8 primary care physicians and 4 specialists is actually Medicare. So there were many of us, but we all roll up into one big tax ID number across many sites. So because of our performance and volume and thresholds, we actually are all contributing to MIPS. I did look up my NPI quickly to see if I could be out of MIPS. That was the first thing I did, and unfortunately I wasn't. So I'm going to briefly show you a couple of how we do things internally. We were on Epic. I've just been interacting with our IT team over the last several days to understand what our workflows are, what our investments have been. I've asked to quantify what our financial investment has been to just stand up the MIPS requirements. And basically I was told that they were too large or too scattered to really congregate and put into $1 amount. But needless to say, it's a lot less than what our bonus that we received which was approximately a 2% kind of MIPS adjustment. And it's not even fair to call it a bonus. It's really just kind of meeting some of these performance goals. I just decided to take some of the things that I had to do at the staff level and then what we have to do to coordinate the builds in our electronic health record. And because of changes in requirements, we're going to have to just keep doing these continuous changes and builds. I'm not going to read the slides to you. I think the more interesting thing, and I'm not expecting you to read, this is my personal dashboard. And you'll see that I have a lot of reds in areas which, tell you what probably a practical practicing physician experiences. There are some things that have denominators that don't apply because they're not relevant to my population, but because of our need to build across an entire system, they're put onto our dashboard. I bring up the granularity of my personal dashboard, one, to drive home the point that as a practicing physician, I actually don't ever use this dashboard. It's completely meaningless to me, especially since there are so many things that don't apply to me personally, yet this is considered customized for myself. And then at the same time, I think one of the greatest opportunities, and Tim Groniger and others at Brookings and I have discussed this, is that I don't really know quite what to do to improve in areas where I do have kind of red and I need to go into green, like closing referral loops for specialist reports, which I feel like is part electronic, but much of our work, especially at a place like Johns Hopkins where we get a lot of referrals and then send out a lot of referrals back, is done over fax. So there are things that are just very kind of complicated. I don't want to go through each of these steps, but did want to show you what a very practical, on a daily basis, kind of what our view as a practicing physician might look like. And then I do have the ability to do a lot of things inside of my health record to kind of look at patients and look at things. Quite honestly, I don't have the time, nor do I have the motivation to do it. And I asked just to kind of put a little finer point on this, some of the recent changes around the MIPS program that have been proposed last week, which I think in general are positive changes. My question to our system leadership was, what do we sacrifice? What are we not going to do because we need to do some of this activity around getting the dashboards up, getting the workflows right? Something as simple as measuring blood pressure alone and reporting on that quality metric can take approximately 200 hours of kind of time on the electronic side, and then on the physician workflow side can take even 5 to 6 times that. So we've spent almost 1,000 hours, like in aggregate, across our practice and across different personnel to really understand how do we implement measuring and then controlling hypertension. So I bring that up because at the same time, we're also trying to we are a level 1 accountable care organization. And the truth is that a lot of the activities we're doing in MIPS, frankly, are coming at a cost of our ability to advance in other, I would say, quote, risk-taking, population health-based models, because it is a fixed-sum game. There's only so much time that I can ask of fellow doctors and medical assistants and front desk schedulers, and then there's only so many resources that we have, primarily on our IT side, to actually help us do some of this. So with that, I just offered a little bit of a pragmatic view from my perspective, but I think a lot of my colleagues would echo this and kind of say the same thing. So I'll hand it over to Valinda. We're going to go through, each speaker is going to have kind of our presentation, and then we'll have a Q&A period afterwards. Thank you.
Thank you, Kavita. Thank you, Abby. I don't know if I could figure out how to pull the slides up.
I'm sorry, I left.
I'm Valinda Rutledge. I'm the VP of Public Payer Strategy at Greenville Health System. Thank you. There we go.
Is it on? Okay.
Yes, great. Greenville Health System is a part of a new health company. We recently merged with Palmetto Health, so GHS and Palmetto Health has come together. As you can see, we're one of the largest systems in South Carolina. We have a total of close to 2,800 physicians in our CIN, and about half of them are employed and half of them are independent physicians. So that's pretty unique. A lot of CINs either have a predominant of employed physicians or it may be much smaller with a large amount of independent physicians. What also makes this unique is because South Carolina, it's a little bit different than the Northeast. We have a large amount of rural areas. So we have 32% of our practices that's in our CIN is in, you would classify as small practices in rural areas. So the ongoing rural challenge that we've had in MIPS is that the EMR vendors require significant upgrade fees and rate increases in order to have upgrades in the product to be able to report MIPS requirement. So not only do you have the initial investment that you have in putting the EMR in, that you also have yearly upgrade fees that are pretty substantial for rural providers. Second, in quality outcome measures, the absence of a risk adjustment is not addressing the older and sicker populations that you currently see in the rural area. As you know, currently in MIPS, smaller practices have, you can get a small practice bonus, but that still does not level the playing field in the competition between the rural and urban practices that you will see. Also, there are very few alternative payment models that urban providers can actually participate in. The fourth issue is a lack of connectivity that many rural providers have with other rural providers. Many of the SNFs that are in rural areas lack any type of EMR. So that makes it very difficult for rural providers to connect with other rural providers in their area to be able to have effective integration activities. Also, rural providers have been running lean for decades, and they simply don't have enough staff to be able to address all the MIPS complexity. Many of them, as you know, may have 1 or 2 providers in the office, may have 1 mid-level provider and a part-time office staff. So that's a very lean operation that makes it very difficult for them. And final, the MIPS implementation costs far exceed the potential for positive adjustments. The number of the number of billings that they have, the ones that do not qualify for exemption, the number of billings that they have are very, very small, and yet the cost of the implementation in terms of implementing MIPS requirement far exceeds that. So I am going to share with you a tale of two cities. So the first tale is our MIPS negative RI. So once upon a time, we had a very large and sophisticated clinically integrated network that had 30 to 35% rural providers, which means that they need an extra amount of time to be able to comply for MIPS. We recognize that we had to spend a lot of time in terms of helping our partners be able to comply with MIPS and able to deliver a high quality care in the areas that we serve. So we spent a lot of energy in terms of giving them extra resources. We hired staff. We spent side by side with their practices. We would actually go into their practice and sit down with all members of their teams. We hired dozens of additional full-time staff that we calculated we worked tens of thousands of hours to provide the education, the support, and the information technology resources that was needed to meet the MIPS requirement. And we did so well that we ended up close to 95% when we got our MIPS score back, which made everyone, the 2,400 physicians, very happy, until we realized that that 95% gave us 1.59% payment bonus. And that included the exceptional performance bonus in that. We calculated out what that was compared to the cost that we used, and it came out to 60%. So for every dollar we spent in complying with MIPS, we only got 60 cents back on it. And as you can imagine, that's not a sustainable system going forward. So the second tale is then we had to really look ourselves in the mirror and say, so what should be our next step? Do we stay in MIPS, in which we can hope that we can do better than 60 cents on the dollar? Or do we need to take a look at it from another perspective? And so the perspective we chose to begin to look at it is that MIPS has to be a stepping stone in terms of looking at the competencies to move into advanced alternative payment model. Without being able to get that 5% bonus in advanced alternative payment model, there is no way we can continue to survive in terms of getting 60 cents on every dollar that we put in terms of just complying with MIPS.
Great.
Thank you.
Thank you, Belinda. We'll have time for questions. I'm smarter now. I'm going to help Sherry get the slides up while she comes up here. All right. Since I saw how to do this, I thought it would just be easier. Okay, there you go.
You're good.
Yeah,
All
I told you I
right.
learned quick. Except there we go. Should be up.
Excellent. Thanks. So I'm Sherry Erickson. I'm Vice President of Governmental Affairs and Medical Practice at the American College of Physicians. We represent 153,000 internal medicine physicians across the country and some internationally as well. Our membership is made up of about half primary care general internal medicine specialists as well as subspecialists in all different types of internal medicine, oncology, rheumatology, pulmonology, lots of ologies. So, and so we do have kind of a unique view on this because of the makeup of our membership. And even within the membership, our members are in academic centers, they are in track, 2 ACOs, they're in pioneer ACOs, they're in small practices. I would say, though, that probably most of our members, a large, significant number of our members, are in the MIPS program. And that was expected just as it was across all of the eligible clinicians that were participating or in MIPS. So I hear a lot about it from our members and wanted to reflect on some of the things that I've been hearing from our members and sort of give you some buckets of what those look like from their perspective and their experience within MIPS. Let's see. I got it. So I kind of grouped it into a few different areas. And measures is a biggie. So, and this has come up. But I would say what I hear about most from our members is the fact that they really don't trust, they don't believe that these measures that they're reporting on are ones that are meaningful to them, their practice, and their patients. And I think that there's a lot underlying that, and that's not unique to MIPS necessarily, really it cuts across, I guess, all of value-based payment programs. But it's something that I think we need to start to address, and I'll talk a little bit more about that as well. There are too many and yet too few measures. So, when our Performance Measurement Committee looked at the measures that are included in the MIPS program, I think they found about a third of them are viewed as clinically valid. That should be, used by clinicians in the field. Yet, really, when you look at it more broadly than that, there are measures that are sort of in those other sets that are, quite frankly, maybe more meaningful to patients or to other stakeholder groups that are also involved in this process. So we need to be very thoughtful about how we look at those measures that are included in the program. And yet, also, there are too few. Some of our subspecialists really do struggle with having enough good measures that they feel are meaningful enough to use when they're reporting for the program or any value-based program. And then there are multiple alignment efforts, and I mentioned the work of our Performance Measurement Committee, but there's also work within NQF to endorse the measures. There's the work of the MAP, which provides the sub-regulatory, pre-regulatory guidance to CMS. There's the work of the Core Measures Collaborative that has identified sets of core measures and is going to be getting up and running again soon along those lines. So in each of those movements, so to speak, or entities have had different approaches for actually very different, very good reasons because of the different stakeholders perhaps that are at the table and the different types of goals that they have set for themselves. And so we need to think about that, and I'll talk more about that in a moment too. Another big bucket is the health IT overall. Our members are very frustrated with the health IT, with the EHRs that they use daily. The usability of those is an extreme challenge, and particularly when you tie it into the need for reporting. Layers in additional what they feel are validly are very unnecessary additional clicks, additional data entry, re-entry of information, and the readiness of vendors, which is a real challenge. So the vendors, I think this came up earlier when Kavita was talking, have to upgrade, and then the practices need to pay for that and be sure that it's there in time for them, with a full year of reporting required for quality and proposed again to be required for quality. That's a real challenge if the health IT is not up to speed and ready to do that. And meaningful interoperability, and I put meaningful in quotes because meaningful is used all over the place in this town. So, but what I mean by that is that we do need to share all the data, right? We do need to have those flows in place, and we don't want blockage of that data. But when physicians really are taking care of a patient and they have someone in front of them, they don't need every piece of data about that patient in front of them. They need what they need to be able to pull at that time to help that patient in that episode of care. And that is where we need to try to get to, and that is not where I think that we have gotten to yet, and it needs to be a place where we start to think very thoughtfully about what we mean by interoperability. There's a lack of clinician engagement and understanding. And when I think of engagement, I think of, so if you're in a larger institution, you have some leaders who may be physicians or clinicians in a C-suite or somewhere thinking about looking at all the data they have available and what are the real measures and what's the smart way to go about this. How can we do the best we can do in this program? And But then you have the frontline clinicians thinking, well, they told me I have to report on this. I don't know why. It doesn't mean anything to me necessarily in this clinical encounter that I'm in, or in the 20 of them that I did today. So we need to figure out how to engage those clinicians in this decision making as well. And then when you get into smaller practices, less integrated systems, there's a real lack of understanding and ability to make those decisions with the same level of data, and then much less know how to report it, because there are lots of different options and different timing around it. And then clinician accountability in what is a very fragmented system. Patients, may be very tied into their primary care clinician in terms of all of their chronic care for their multiple chronic conditions, yet they may have a need or a want for very valid reasons to see a different clinician, a different provider in another setting because of, maybe they're traveling, who knows, maybe they're just sick in the middle of the night and they need to go somewhere. And yet there's no really good way for that information, this gets at interoperability again, to necessarily get back to that primary care clinician on a consistent way for them to be able to then be accountable, then they're still accountable for the patient themselves. And that happens across organizations and within organizations as well. The complexity of the program, I've hinted at that. It really doesn't need to be as complex as it is. There are certainly some parameters within the law that are required to be met, but and then the scoring also doesn't need to be as complex as it is. The annual changes, this I think came up and will come up some more. Not only lead to a lot of additional cost, they lead to a lot of additional confusion and lack of an ability for an organization, large, small, or in between, to plan ahead. And MIPS still does require sort of your feet in both boats. It requires you to be fully invested in fee-for-service. You still have to document every code. You still have to do all of that work while, by the way, trying to sort of inch your way into what's called value-based payment. And it's not easy to transition there. So is there still value? So I've laid out all these challenges, what I hear about on a regular basis from our members. And I would argue there is still some value in the program. The intent of the program is really to streamline and tie together some existing very disparate programs that were out there. And if you look at what's going on, ACP does quality improvement programs across the country. And I will tell you, those things work. When you implement those and implement them well, and they may actually mean that the physician or clinicians or the staff have to do some extra steps, document maybe some extra stuff even for that quality improvement work, but they don't generally mind that because they actually are engaged. They actually see that it's meaningful to themselves, to the patients, to the outcomes of those patients. So how can we figure out how to translate what we're learning there into the MIPS program? And alignment and improvement of measures, I don't think it's out of reach, but it's going to take real courage wrapped in compromise. All of us are going to have to think about that. We still need to fly this plane, but how can we actually make some changes to those measures? How can we actually get rid of the ones that are really not good measures, but also address the issues that many subspecialists or specialists are facing with not having enough, and get to a place where the measures are trusted, because there are some that are trusted and viewed as valuable by clinicians. How can we get to a place where we use as many of those as we can while also getting to the measures that are more consistent and useful and helpful to the patient? And so I think we just have to really think through how to do this and be a little bit courageous about it. I think MIPS can actually be simplified and streamlined. I think that there are more, and I could talk all day about that, but I want to also get to our other panelists. There are more pathways and more on-ramps that I think could be put in place to get to APMs, freeing up some of that work that's being done to rebuild, to do that so that Kavita's organization could actually invest in population health instead of having to rebuild based on the tweaks in MIPS. And then practices and systems can, and many actually do, take very thoughtful approaches to their decision making around the measures that they're using and the approaches that they're taking. And we need to learn from them. They're not all looking just at the bottom line. Some of them really are engaging the clinicians on the ground and making very thoughtful decisions based on what they have available to do this work. So how can we learn from that, and how can we actually reward those individuals and groups?
Thank you, Sherry. All right, Erin, go ahead and come up here. Got a workflow while I get the slides up. Okay, there we go. And then you should be good with this.
Great. I'm Erin Liss. I'm the Director of Strategy and Business Development with Tennessee Oncology. For those of you who are not familiar with Tennessee Oncology, we are one of the largest wholly physician-owned oncology practices in the country. We have over 80 oncologists, including medical oncologists, radiation oncologists. We have our own specialty pharmacy, as well as a Phase 1 research program through our partnership with Sarah Cannon Research Institute. My role there, I have, in the 4 years or so that I've been there now, it's been primarily focused on finance related to value-based payment, as well as supporting our operational initiatives in our value-based payment programs in which we're participating. So I wouldn't refer to myself as an expert on the ACO program, but I think there were some interesting lessons from that program that are relevant to the APM that we are participating in, Medicare's Oncology Care Model, as well as to MIPS. And so one of the sort of things I would point out, does this thing work? No, it doesn't look like it does, you know, you see kind of, you start to see a spike in groups who were successful in this program once you get about 2 years in, and then again at about the 3.5-year mark. So I think that just sort of illustrates the complexity of these, you know, new payment models, whether that's MIPS or whether that's a new APM, and how long it takes organizations to, you know, to adapt without sort of multiple rounds of data and feedback loops, you know, in that experience. It's really hard to, you know, sort of get to that point. And these are organizations that self-selected themselves for having a high propensity for organizational change. So, you know, in terms of sort of the impact of MIPS so far, I think one model, one framework we can use for that is to focus on the quadruple aim. For a second, I'm gonna assume y'all can concede that workforce health is a you know, severe issue. I'll talk more about that. I'm sure you know, we're going to talk more about that on this panel. But in our analysis of the link between patient experience and these programs, you know, we found that that, you know, it's the gains we've made in patient experience in our analysis of internal surveys are made despite these programs, despite the attributes of these programs, and not as a result of those attributes. And I think that it's really, you know, sort of the responsibility is on proponents of these programs to justify the, you know, the cost to workforce health with the benefits to health outcomes and total costs of care that, you know, purportedly we should see in these programs. So, you know, I think the high-level intentions in terms of increasing provider consideration of cost of care and introducing performance-based variation in reimbursement, that's not a really sufficient justification for you know, continuing these programs in their current form, because there's other more effective ways that we can accomplish those sort of fundamental objectives. I think we really need to, the standard really should be higher order accomplishments, such as feeling that reimbursement is commensurate with provider influence over outcomes, and really showing that these, if there are, to the extent there are gains in costs of care and health outcomes, that those cannot be achieved some other way through some other type of program that doesn't have the level of burden on workforce health as well as patient satisfaction. And I think, we've created a system with these programs that is, increases the perhaps satisfaction of public health researchers with the granularity of the data that will be available, or for people who sell HIT systems at the expense of providers being able to look up from the screen. And I think that, that's, we really have to be more thoughtful about how we are striking that balance. And then, in terms of organizational economics, I would, in one of the interesting things about the APM in which we're participating is that we are required to report how we are investing in that program each year. And sort of very quickly, it becomes apparent in that analysis that the cost of FTE time, far exceeds any revenues that we, garner from the APM or from MIPS. To the extent that FTE time is about 4 times the cost of the FTE resources, are about 4 times the revenue from combined revenue from MIPS and the APM, and I'll concede that those are costs that we would take on to do something else for some other types of activities, as Kavita mentioned, but they are real costs to that we have to allocate, real time that we have to allocate to these programs. So, I think basically as we increase the sort of multidimensional performance evaluation, all of the requirements we have to meet that are associated both with our APM and with MIPS, we raise the resource investment necessary to perform well in these programs, and we reduce overall workforce health. And I think so far that those 2 things are way out of balance. We can't measure everything. We shouldn't need to report everything. We really need to be more judicious in terms of focusing on, what's really important and what's really going to move public health outcomes and total cost of care. And so I think there was a really interesting article written by my co-panelists in Health Affairs that proposed sort of focusing on APMs as a potential remedy for some of these issues that we're seeing for in MIPS, and I think that type of solution has a lot of potential, but sort of similar to the gap between intentions and reality that we've seen in MIPS so far, you have to get the structure of the APMs right in order for them to sort of render those benefits. When the downside, sort of the stop-loss downside of the APM is 15 times the small incentive we get from participating in an advanced APM, we're not going to be driving provider organizations to those options in a way that we could if we balanced those issues appropriately. So I think that's as much as I'm going to cover for now, and we'll have time for questions.
All right, thank you, Erin. Let me get last but not least, Tim, get you set up here. All right.
All right, good morning. I'm really happy to be here today. So just a quick note about me and Caravan Health. I work at Caravan Health, and we are a company that helps health systems and physicians create and operate accountable care organizations, as well as operate other value-based purchasing programs. Before this job, I spent a number of years at CMS and on the Hill working on physician payment policy, among other things. And so I certainly am happy to shoulder my fair share of the blame for the MIPS design and operations. And so what I want to talk about today is I summarize what I think heard from people representing physicians and provider organizations, that MIPS isn't working if we were to define what we think Congress was trying to accomplish for the program. But I want to get to MIPS actually, I think, can't be made to work to accomplish the objectives that Congress laid out for it, which I think if you listen to how people spoke about it, if you look at the design of the program, it's really intended to drive quality improvement, to drive attention to total costs of care, sort of like creating an alternative payment model for the entire fee-for-service program that is not in alternative payment models. But it was also designed with an intent to differentiate performance of physicians and try to measure at a physician and clinic level the performance, so that patients could use that information to choose physicians, high-quality physicians, and thereby reinforce quality improvement incentives. And it was also intended to create incentives to join alternative payment models, which offer a more direct and clinically nuanced way to support quality improvement and total costs of care. And so just to summarize what I think we're hearing the problems with the program today, it's a very administratively complex and difficult to manage program from the perspective of a clinic or practice administrator. That requires a lot of staff time to deal with. It requires a lot of investment in IT resources. What we didn't hear was MIPS has motivated me to put in place the best industry standard PDSA cycles to identify the major needs of my patients. I think what we see often is that it motivates the choice of the easiest measures. And so that's really where I'm going to start, of why MIPS can't be made to work. Congress laid out, in trying to maximize physician independence and autonomy while also supporting quality improvement, a system where physicians and clinics would be able to choose the measures on which they're judged. It also allowed it set physicians in a position of having the single highest stakes value-based purchasing program in Medicare. And these are the smallest actors of significance that we deal with from a Medicare fee-for-service position. Medicare Advantage plans, effectively their value-based purchasing program is 5 points. In some cases it's 10. These are giant companies that have the ability to manage that risk and to plan for it over a number of years, spending hundreds of millions of dollars in the process. While physician offices, the theoretical plus and minus for them, when you get out to 4 years implementation, is -9 to plus more than 30. And so that's a huge spread, and I think looking at the negative is the cleanest way, but even -9 is a really big number for clinics in a context where you then ask them to turn around and to do real quality improvement work. And as Sherry described, the measure choices that physicians face, there's a huge number of measures to choose from, and then in some subspecialty areas they feel that they do not have enough measures to choose from. And I want to pull up a table from a paper that Kavita and I wrote, along with Matt and Fiedler and Paul and Lauren Adler and a few others, around what is the operations of MIPS likely to look like over the early years of the program, based on what we knew from physician quality reporting programs that preceded MIPS and then essentially were rolled into MIPS. And so what we found is that if you look at this strong incentive to choose the easiest measures possible, resulted even in a program where there was no attachment to your performance in PQRS. It didn't matter what your score was in PQRS. But even with that, clinicians gravitated towards the easiest measures. And the number one measure by far in the program, and still to this day, is documentation of medications in the record. In many cases, you could argue that that's effectively a state law requirement. We have this giant apparatus built up now, spending hundreds of millions of dollars at the federal level, and multiples of that in the private sector, to encourage reporting of measures that are really easy in many cases, or should arguably be basically standard of practice. Now, CMS, I will note, is aware of this and is trying to rotate out topped-out measures. But for reasons of political economy that I'm going to talk about a little bit more in a minute, that ends up being really hard to do in a sustainable way over time. So with this really strong incentive to choose the easiest measures, you end up with practices choosing the easiest measures, of course, but then not spending that time focusing on real quality improvement, but having their IT staff do quality improvement, turning it into a compliance exercise, not really looking at their total cost of care. Excuse me. Let me see. Should I go to this? So the fee-for-service system that we have here, Congress really faced a dilemma in. Thank you. In the design of the program here that I outlined around clinician choice and the impact of the program, right? So the high stakes seems like, well, if you're dealing with a -9 to +27 or +30, it seems like that's a pretty strong reason to do well in the program. But if you pair that with measure choice, then you will have a really strong incentive to choose those easy measures. The alternative to that is what is done in APMs or in other contexts, is to define a list of measures. Public-private cooperation, we need a lot of clinician input, of course, but in an ACO context, for example, there are 30-ish measures that are reported. About 15 of them are reported from clinical data, and the other half are reported from claims, and they're known ahead of time, and they're curated, and the organization can improve performance on them over time. Some of them are easy, some of them are hard, but it's a back and forth. Here, you've got this situation where Congress, in trying to put in place a high-impact program, wanted to give as much choice as possible and undercut their ability to do that with the choice. This is not something that can be fixed by tinkering, because you are always going to be looking to encourage that choice, and also because we have in our minds this, if we put in place the right incentives for these organizations, then they are going to figure it out. But paying physicians is really a lot more like paying employees or paying very small businesses in many cases. Not that physicians are employees of the federal government. Obviously, that's not the case, but they're not in a position to put in place the business processes that a hospital is, say, in the value-based purchasing context, where they are able to invest significant resources in quality improvement on a defined set of measures over time. And so this problem becomes even more clear, and our paper goes into this in more detail, when you look at the construction of the cost measures that are an increasingly large part of the MIPS program. It started at 0% in 2017, up to 10% this year. CMS is proposing to take it to 15% for next year. CMS has gone through 3 batches of proposed measures in 3 years for that part of the program. And because you have to account for very small practices, they're looking at measure thresholds of 10 cases per year for some of the new episode measures, 20 cases per year. That is obviously going to be difficult to justify in terms of is that a good representation of any particular clinic's performance? It leads to huge disagreements with the medical community, and it's not something that can be solved with statistics or simply trying harder. This is going to be an intractable problem. You also have conflicting incentives in the cost domain, where hospitalizations are counted twice because they're counted in multiple episodes, and so it's truly a mess on the cost episode piece of the program. And so I'm going to wrap up here so that we can get to questions. But as I've said, this is something that can't actually be fixed by simply tinkering the way we would normally try to improve. Some of the, say, an innovation center project can be modified every year or multiple times per year. Congress has revisited the hospital value-based purchasing program multiple times, and it is functioning more or less as intended. Hospitals are tracking difficult, in some cases, measures and improving on them consistently. We've seen reductions in readmissions, but it has also been tinkered with by Congress. In the case of MIPS, the costs of the ongoing program are very large in terms of wasted clinical time wherever we have physicians working on this program instead of focusing on their patients' needs. Significant administrative overhead in the private sector in particular, and also some lost urgency around moving to better payment models and payment models that can be made to work better over time. So from my perspective, and that's the argument of the paper, I still believe is true, it's much better for Congress to get involved now and to greatly simplify the program, to forget about trying to connect performance on a small list of measures to large payment adjustments for physicians, and to move to a simpler set of incentives to promote quality improvement processes and adoption of alternative payment models. I'm going to stop there.
Great, thank you, Tim. And we'll go ahead and get started with I know we've got about 10, and we'll see where the conversation goes, maybe 15 minutes, so that we can have a discussion. I'm actually going to start, I wanted to ask Erin very briefly, just because I don't know if everybody understands, but I'd like for you to answer, if possible, at kind of a very granular level. You alluded to, you're in both reporting on MIPS, because you're also only in an advanced payment model, not an alternative payment model, not an advanced alternative payment model to get that 5% bonus. Just given everything that you described, how hard is your organization going to work to try to get an AAPM designation, or is that the goal? And you're speaking kind of not on behalf of oncologists, but certainly as specialists are looking at opportunities. So just very briefly, do you have a sense of whether or not, as an organization, the AAPM looks more attractive, if possible, to get away with this duality that you described?
I think the way the advanced APM sort of structure exists currently, I mean, I would hesitate to use the word non-starter, but I mean, it's completely draconian in terms of the potential losses that a participant could incur on the downside, and compared to the potential upside of participation. Having said that, we took the step of participating in a MIPS APM for the reason that we are committed to moving towards, value-based care and value-based payment programs. All of the practices who participate in the oncology care model, presumably a lot of those in the other CMMI models, self-select themselves for, their intention to innovate in that way. But you do kind of hit this roadblock when the numbers sort of add up the way they currently do in these, with those two options. Is that what you were asking?
Yes, and then just very briefly, the MIPS APM, because you're reporting on both MIPS and you're doing the APM requirements.
So
how much
through
time?
The APM, we aren't able to select the easiest measures to hit. The measures that were measured against are sort of dictated by the structure of the APM, and the improvement activities are the most complex of improvement activities that we have to perform as part of the APM. And then we also have to do the advancing care. So it's we have the much more stringent limitations in terms of options for participation in MIPS, but yet despite all of the I should also mention that the clinical data reporting associated with the oncology care model is incredibly robust. It's very cumbersome. It takes several FTEs, working for several months to do that clinical data reporting. And then on top of that, we still have to do the ACI portion of MIPS. So I think that is one of the things that could be rethought.
All right, great. Valinda, you made several points, one around kind of the challenges of rural practices, and then you also kind of alluded to the desire to potentially find an advanced APM just for the sake of getting out of some of these challenges. So can you speak, number one, just to clarify, because I think a lot of people have a misperception that if you're, quote, rural, that you're really automatically exempt from these MIPS requirements. Do you mind just clarifying for the audience? And then number two, could you also speak a little bit, we can't, Tim eloquently kind of described that MIPS can't just be tinkered with, and it really does need to be replaced. And maybe describe a little bit about how operationally at a health system of kind of medium to large size, how are you thinking about moving forward when you have to live in the current environment? Are you as a system trying to get an AAPM? And if so, what is your forecast on when that might occur? Yeah, you have to, Erin, press off, and then I think only one can, okay, good.
Okay. So we have found that there's certainly a significant number of rural providers that meet the exemption category, but we should not assume the vast majority of them are exempt from it. And even the ones that are exempt, particularly if those providers are not near retirement, they really understand that they need to get into the game. They need to understand how to work within this new environment. So even if they may complain about it, when you go into their office and, they'll roll their eyes and say, there goes the government again. You can imagine some of the conversations we have. The vast amount of them say, I need to get an EMR. I've got to figure out how to work within this. And so one of the things that we have found is they're eager to join CINs to help them because they understand that they need assistance. Now, I do know CMS has provided some of that additional assistance, but it's not at the level, I think, that many of the rural providers are feeling comfortable with, and it's certainly not the level that somebody that's in their own town and goes into their office and drives to that rural city and sits there that they can provide. So with that, many of the rural providers around us have been very interested in being a part of the CIN so that we could assist them with that. We made the decision to go with a advanced APM, a Track 1 Plus. We selected the one that had the least amount of downside risk. You can imagine with 2,800 providers and 30 to 35% of them in rural areas, we went to something that had the least amount of risk. And we're really glad that we made that decision after getting our 1.59% bonus. I will tell you.
But you made that decision without knowing that was
right.
Right. So you had to make that organizational decision.
We were making it on the assumption that we would get around 3%.
Interesting. Okay.
We didn't think at a 2,800 person system that we would probably reach the top at 4%. So we were anticipating we'd come in between 90 and 95 and spending, millions and millions of dollars. We probably spent close to $7 to $8 million in helping the system, the CINs, comply with it. And we, as I said, 60 cents on the dollar. So, certainly a 5% bonus will help offset that, particularly from the employed docs. The independent docs and the rural providers will get that directly themselves. But that 5% bonus will, from the employed docs, will help the system as a whole offset all of that investment we have put in for the system as a whole to move up, that CIN to move up in terms of competencies, in terms of population health.
Great. Sherry, you spoke about a number of activities. Obviously, the ACPs sounds like you're supporting kind of quality improvement programs and more kind of collaboratives that are, it sounds like they're more meaningful. How, kind of thinking about what Tim mentioned with the struggle from a policy perspective with including a lot of measures for the sake of political economy, how can we transition potentially? Do you see an opportunity to take kind of the meaningful activities that are coming to the ground level, which I've been kind of using for the kind of clinical performance improvement activity bucket, in terms of meeting MIPS requirements. Is there something that should be translated into the broader quality measurement requirement or some way forward? Because I know when we've spoken before, we've all said we're not in love with MIPS, but don't throw it out without thinking about what to replace it with, which is also something Tim echoed. So what is it that we can do to bridge what you see happening on the ground and what we see at a policy level?
Sure. So I think that a lot of what's going on the ground with some of the quality improvement activities or improved quality improvement programs that are going on are really tied in to clinical guidelines and measures that have been viewed as valid. And I think one of the things that I think we could do, and I hear what Tim is saying about the issue of we can't just tinker with the program. I actually think there's quite a bit more flexibility than might be viewed, so to speak, by some in terms of what the law lays out and relative to what we can do. I think that we need to be pretty open-minded about that. So if one were to think about really taking a quality improvement activity, which includes the activity, right, that component of it, most of the times those activities do include using health IT in a meaningful way to do that work. They also include the measures, right, because you have to have measures to be able to measure whether your quality improvement activity or your quality improvement program is working. They also include looking at cost for the most part. So these programs are looking at those components. How can we have those types of efforts count across it all? I mean, that's really what's intended here, right? We had separate programs. We had value-based program. We had PQRS. We had, whatever else. We had meaningful use. Thank you. That's it. So we had all these programs that were intended through the law to be brought together. Well, I think that, we still have in many ways, 4 siloed programs within MIPS. And I don't think it has to be that way. It just doesn't. The law doesn't say that it has to be that way. So I think that's what we need to do is be thoughtful about that. Let's look at how we can actually have things that individuals and programs and practices are doing and give them that credit across them. Maybe it's through even things like safe harbors for those that test this out for the administration to give them ideas to be able to translate this into the policy that's needed to do it. I think that's one, practical way we could think about it, and there are probably a number of others, but I'll stop.
No, that's great. Thank you. And then, Tim, I'm going to give you a 2-part question, but we'll close with a very rapid-fire panelist question. Our title of our talk today, title of our program today is Can MIPS Be Salvaged? Sounds like we would probably answer as yes. Let me ask a different question. Were we better off before with those separate programs? And everyone's saying no. But that's if I'll just get to that, and if you say, since we're all going to say no, let me ask it a different way. Are we better off trying to actually do what Tim suggested, where we need to probably replace the program, or do we think that we can do what Sherry described with kind of taking pieces of it and looking at how to just make those pieces work in harmonization, et cetera? So I'm not going to load your answers. But Tim, 2 parts. One, the first thing, you described kind of working, I think your organization works pretty critically with accountable care organizations of maybe different types. I'm not sure if they're all risk-bearing or kind of heterogeneous. Again, this question of do you think that, and largely not hospital-owned, I'm just going to venture just knowing what I know, do you see a trend where these organizations see their path forward, as Valinda described, kind of in an AAPM, maybe a higher level ACO that's taking risk, because that is one way to kind of keep moving along the continuum? And then the second part, I can remind you if we forget, is really around kind of in the backdrop, the trend towards consolidation, which is occurring across primary care and specialties. And certainly I don't see that slowing down, but you should tell us whether or not you think some of the kind of aspects that we've been critical of MIPS today might unintentionally drive consolidation in the provider market as well. So.
So I'll try to answer the first one quickly. So we work with different types of ACOs, including hospital and hospital physician partnership ACOs, and many of them, are in ACOs partly because MIPS is so annoying to deal with. Right, and so, but many of them are looking at the future and saying CMS is going to be making us take risk. We better get practice doing that, and see it as a better way, a more stable way to work on care improvement and total cost of care management. I think that the question around consolidation is a little bit separable from MIPS in the sense of Medicare has to figure out what it wants to pay for, define what counts as high quality, define what counts as reasonable and efficient payment rates, and pay that. I think Medicare is in some cases looking at side of care differentials where I think there's a pretty strong argument that payment differentials have led to consolidation. Those should be cleaned up, but that's sort of separate from MIPS. I think that you need to get the definition of what you want the program to reward straight, and then empower people in the private sector, firms, people at hospitals and physician networks and all across the system to figure out solutions that are going to be efficient for them and for their patients rather than microengineering it like I think we do in MIPS.
Right. Okay, great. So I've taken the moderator's prerogative of changing my lightning round question. So what is, since we're going into the next panel to talk about kind of solutions and strategies, each one of you have mentioned several in your presentation. If you were kind of sitting at CMS today, you've heard all this feedback. Certainly there's the physician fee schedule rule, which has some provocative changes to E&M that I think are also going to color a lot of how we feel about MIPS, to be perfectly blunt. What is kind of the one top priority in, quote, salvaging MIPS? So it could be anything and even a repeat of what you said, but just the kind of the top thing. I'll go first. I'll say to expand the opportunities within advanced alternative payment models much more broadly, including opportunities for primary care. One has argued that ACOs offer that. They don't make sense for everybody, but expanding that portfolio in a meaningful way and harmonizing that with the MIPS requirements. Valinda?
My comment would be don't try to tweak a program that is not working. I think that's always not a good time proposition for us in this industry. And I think we need to look at where we want to end up at and focus on modifying the program for that. And if we feel that population health risk-based contracts do improve the health of the populations that we all serve, then that should be the endpoint in terms of the modification of the program.
Great. Sherry?
Sure. So I think that you have to invest in making improvements in the current program because we have the current program. But at the same time, I like what Valinda just said, though, about let's look at where our goal is and let's make those changes to it looking toward that goal. And I do think that what you and Tim wrote about in that article is very important, that there need to be more opportunities for clinicians, physicians to design and implement and be part of advanced APMs that can offer them really much more meaningful chances, I think, for making quality improvement and being rewarded for that quality improvement.
Great. Thank you. Erin?
So I think... now it's on. I think you have to make the performance evaluation portion of the element of these programs fair for, they have to be highly targeted, as we've discussed, and they have to be understandable at the point of care. The more understandable they are at the point of care, the more successful they're going to be. And I think, we have to leverage some of the work that a lot of the professional society quality programs have done. And, it's not a matter of, getting rid of MIPS and replacing it with nothing, because we already have things to replace it with. We have professional society quality programs. We've, a lot of organizations across the country now are publishing case studies of their quality improvement efforts. We've done that in areas of pathways and appropriate biomarker testing and responsiveness to patients via validated symptom management triage protocols. All of these things that can the folks who the care teams understand and see the value of them, and will meaningfully improve care. When you take away some of the burden, the reporting burden of these programs, you leave more space for those types of initiatives.
Great, thank you. Tim, final word.
Three things, although I would first say I think it mostly is on Congress to fix the structural problems with MIPS, not CMS. I think CMS
So you're in Congress, sorry. You can personally be a member of Congress, yes.
No, I've already got my CMS answer. I can't change right now. The CMS needs to do what they're already doing in terms of reducing the administrative drag and cost of the program. It's got to be continuously made easier to deal with. They need to get rid of the easiest measures, the least important measures for patient care. That's going to be hard. They're doing that a little bit, but I think that there are too many measures in there that are not meaningful for patients. And they need to invest in alternative payment models, like you said, development, but also incentives for joining wherever they have levers in MACRA. I think that they need to be leaning it towards APMs rather than MIPS.
All right, I know we could go on and on. We have a great next panel, so we shortchanged them just a few minutes. But join me in thanking this current panel, and we'll switch out pretty quickly.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.